I want to say welcome officially to all of you. I haven't met each of you in person now, but I'm hoping afterwards when we have some tea and coffee, they're even making our sandwiches, that I'm going to get a chance to just meet each of you personally. Some of you have already met, and it's really lovely to have you here. You might have, and you need to know what to look for in this patient. Now the skull, you don't need to know all the different bones of the skull, but I just want to point out some things that are important. This bone here is called the zygomatic bone or the zygomatic arch. Can you see? Okay. And the reason it's important is usually it's one of the first bones to break because it's very fragile. And I'm going to show you in a moment how it looks in 3D. The other bone, you must understand the skull is thick. It doesn't easily break. So if somebody has had a fractured skull, you know that they've had a severe impact to the head. I'm not saying they have a severe head injury or severe brain injury, but they've had a strong knock to the head. So there's a very good chance they have brain injury. And even if it doesn't show on the MRI scans, you know that you need to test this person to see if it shows up on the cognitive tests, because you know they had a big knock. Now, just give me a moment, because I just want to plug in my little 3D pictures. Oops. Okay. Can you see the skull? All right. Now, some of the important aspects. Now, obviously, you have where the eye sockets, you know, where the eyes go, the teeth, the mandibles, and if you turn it around, you'll see all the various little sutures where the skull comes together. And if you turn it upside down, oh, sorry. Sorry, little guy. Oh, okay, I can't show you now. But you can see the foramen where the spinal cord goes into the skull. Okay. Now, I want to show you something specific. Just give me a moment. Okay. I've now taken away the frontal bone. Okay. Have a look inside here. See those bones that are green? I'm going to go up closer. See those they're like little perforations through the bone. Okay. It's called the cribriform plate, and I'm going to be mentioning it again in a moment. The reason that is important is when the little olfactory bulbs are just above it, and the little neurons actually go through the cribriform plate into the nasal cavity. And it is those little neurons that help us smell and that help us appreciate flavor. But when a person has had a high impact injury, let's say that kind of impact, what tends to happen is that those little neurons get sheared off. So usually for a while, after somebody's had for example, a car accident, they can't smell. But it's one of the very, very few brain areas that regrow. So that sense of smell will come back again. And I'll show you later the pictures that explain that better. The other thing I want to show you sorry. Sorry, give me a moment. Now I'm opening up the back of the head. So I want to show you. Can you see the cribriform plate where it is now with the ethmoid bone? Okay. But these other bones here, look at all those sharp, jagged edges. Now the other thing that happens, why I'm pointing this out, is that if a person, particularly with a car accident, where there's an acceleration and deceleration, rapid deceleration, the frontal lobe moves forward and it scrapes the bottom part of the frontal lobe, scrape against those little bones. Here's my little brain model. Okay. Here are your frontal lobes. So these areas scrape on those bones And that is often why you have prefrontal injury in people who have no other brain injury, just because of those acceleration, deceleration forces. Okay. Just a note on this brain. Our brains, this is bigger than our brain. Our brains are actually very small. But I think for the purposes of just showing how it works and so on, they made the brain a bit bigger. I want to talk more about this in a moment. Remember that the brain itself is quite soft. So it helps to keep the brain in place. And the tentorium cerebelli is this side here. The brain, parts of the brain also rests on it. That tentorium cerebelli comes along here, and it supports this part of the brain so it doesn't rest too much on the cerebellum. Here we go. Here's my picture of the cribriform plate. Here's your skull bone. See, here's your olfactory bulb, and you have these little nerves growing through it, picking up sense of smell. And because when we eat, the food, you know that the back of our mouths and our noses are connected. So the aroma of the food goes up into the nasal passage, and it mixes with the smell, and it gives us our sense of flavor. And that is why if people cannot smell anymore, let's say they've had a brain injury, they can't smell anymore because those little neurons have been sheared, they're not going to be able to taste well either, because they can't appreciate aroma of food. And that is why in interviews we ask people, how is your sense of smell? How is your sense of taste? Now, sometimes patients, if people have a very high impact car accident, they might have what you call a base of skull fracture. But a base of skull fracture doesn't actually mean it's at the base of the skull. It can actually be anywhere in the skull. Why they call it the base of skull, I don't know. Also called a basilar fracture, and it typically involves the temporal bone, the occipital bone, the sphenoid bone, and or the ethmoid bone. The ethmoid bone is there where the cribriform plate is. But it can also involve the anterior bone. So that's why I say when you hear base of skull fracture, don't assume it's at the bottom of the skull. It could be anywhere in the skull. But the nature of the fracture is that it causes tears in the meninges. The meninges are the coverings of the brain. I'm going to mention that now. And with a resultant leakage of cerebrospinal fluid, also known as CSF. And the cerebrospinal fluid, it can dribble out through a person's eardrum, it can dribble through their nose, or down the back of their throats, and it has like a salty taste. So you will sometimes see in medical reports, they'll talk about a clear fluid coming out the ears or coming down the nose. And it's not even necessarily people who've been in very bad accidents, but if there's a leakage of cerebrospinal fluid, they find it in the ears and the nose. I'm going to show you a picture now of what battle sign is, which is a good sign of basal skull fracture and bilateral raccoon eyes. That is like a bruising, like a redness, bluishness behind the ear, is what we call battle sign. And it's one of the signs of basal skull fracture, and it's named after William Henry Battle. Okay. And then bilateral raccoon eyes is like a dark, bluish bruising around the eyes. It's also a sign of basal skull fracture. So sometimes you'll see in medical notes they refer to raccoon eyes. They might not mention basal skull, but because you know basal skull, raccoon eyes are as a symptom of basal skull fracture, you need to assume that person has a basal skull fracture. But don't say that in your report. You can just say that you suspect the person had a basal skull fracture, but you defer to a neurologist because it's not our field. Our medicine is not our field, so we cannot assume we know things in medicine that we shouldn't really, or that we're not qualified to. Now, I just wanted to put the CT scan in for you. You see this tiny little line there? That's a basal skull fracture. So it can be very, very small. Do you see it where the yellow arrow is? Just like a thin little line through there. So the radiologists have to look very carefully to see if there's a basal skull fracture. All right. Now the meninges are the covering of the brain. You have these different layers. You have your scalp, okay, the skin. You have your skull, which is obviously bone. Then you have your dura, which is a very thick, strong layer. Your arachnoid, or also called arachnoid mater, which is like a net over the brain, and it's almost slightly spongy and has liquid, well, not liquid, has cerebrospinal fluid in it. And your pia mater, which is like a skin outside of your brain, and then of course the brain tissue itself. Now the reason you need to know that is because if there's been hemorrhages, bleeds on the brain. Before I mention that, I just want to point out here, this picture here depicts the top of the skull. And this area here is what they call a sinus. It is an area where cerebrospinal fluid flows. I just wanted to say another thing about the cerebrospinal fluid. Later you'll see how it has a certain pattern of how it flows through the brain and then through into the spinal cord. So you all know that you have cerebrospinal fluid in your spinal cord, and that's where they do lumbar punctures and so on. So if they're concerned about something that's going wrong in the brain, they often do a lumbar puncture in the spinal cord because it's too dangerous to put a needle in your brain. Okay? So, and when we get to that part, I'll show you the various little ventricles and things that it runs through. Now, as we go through the anatomy, at the same time, I'm going to explain some of the pathologies. Because while you're trying to understand how a certain piece of anatomy works, it's easier to understand how the pathologies work. So when it comes to meningitis, meningitis is the inflammation of the meninges. And whenever you have a word ending in itis, it means there's inflammation, like pancreatitis, tonsillitis. Okay. So meningitis is really just the inflammation of the meninges. And it's caused by either viruses or bacteria or possibly other microorganisms. And the common symptoms are headache, neck stiffness, fever, confusion or altered consciousness, vomiting, photophobia, and phonophobia. Now, these are patients we don't normally assess. When they are experiencing the symptoms, they go straight to the hospital to be treated. But it's important for us to understand it because afterwards we might be assessing the patient to see if there's been any damage as a result. The diagnosis is usually made with a lumbar puncture. And meningitis can lead to serious long-term consequences such as deafness, epilepsy, hydrocephalus, and cognitive deficits. Now, more pathologies to do with the meninges, and this is why you need to understand what the meninges are. An epidural hematoma. Hematoma means blood, collection of blood. So epidural hematoma means that there's bleeding between the dura mater and the skull. So it's above the dura. Subdural hematoma means there's bleeding under the dura, between the dura mater and the arachnoid mater. Okay. So this can be really important to us because if it's a hematoma that is above the skull, it's not going to be putting any pressure on the brain. If it is beneath the skull, it is very likely to start putting pressure on the brain, and particularly if it's underneath, if it's like underneath an arachnoid, if it's a subarachnoid hemorrhage or hematoma, it's going to be putting pressure on the brain. Here's another picture of a subarachnoid hemorrhage, bleeding there, and an intracerebral hemorrhage means bleeding within the brain. Obviously, that is very serious then. Okay, I'm not going to, I've already mentioned this. Okay. Do you have any questions about the meninges? All of the information you'll find in the books as well. Okay. So let us talk about the blood supply to the brain, because blood supply and how the blood flows is very important, and the effects of blood on the brain. Obviously, the brain needs blood because it's carrying oxygen to the brain the whole time. But if that blood escapes from the veins and arteries or ruptures for whatever reason and bleeds into the brain, it damages the brain tissue. And that's when we have things like strokes. So let's have a look at that. You need to know, and there's some good diagrams in your textbooks, you need to know where the main arteries are and where the main veins are. These pictures just illustrate where the veins and where the arteries supply blood to. So the anterior cerebral artery supply, okay, I just want to show you, here's the cerebellum, this is the front of the brain here, that's the back of the brain. So the anterior, meaning front, cerebral artery, not surprisingly, innervates the front of the brain, but also medially on the inside. The middle cerebral artery innervates more the outside, the lateral sides of the brain. Okay, lateral is always on the sides, medial on the inside. And the posterior cerebral artery innervates mostly the posterior areas. But I wish it was as clear-cut as that. Unfortunately, it's not. But this following illustration should help. These colored areas show you which brain areas are innervated by which arteries. Now, this is a slice like this, okay, so you're looking forward. And this blue section, oops, sorry. This blue section, this medial section in the middle, is innervated by the anterior cerebral artery. This yellow section by the middle cerebral artery, including the deeper areas. And then the posterior cerebral artery innervates here, as well as those deeper areas. Now, this is important if you have a stroke patient, because certain stroke patients will have certain effects depending on which artery and which veins have been blocked. This picture really it's just to illustrate this circle of Willis. I don't know if you've heard of the circle of Willis. It's like this, there are various arteries coming and they meet, and there's almost like a traffic circle that they flow around and out. Now, you need to know which of these arteries and so on are flowing in here, but they fall under the brain there. So you're going to have your main arteries coming up here, and your circle of Willis is going to be underneath here, and then it flows out from there. Now, why the circle of Willis is important to us is that if there is a blockage in one of those, it's actually okay, because the blood will still find another way to get to the areas it needs to get to. So if a patient is going to have a blockage in a artery, circle of Willis is a good place to have it. This is just an illustration of the brain upside down. I can imagine there, like that. And again, the circle of Willis there. Oops, sorry, where's it gone? There's your circle of Willis around there. You're welcome to come and have a look at my brain model afterwards if you want to. Just while I'm busy showing you, here are the olfactory bulbs. Okay, that I was speaking about earlier. Now, the circle of Willis is made up of the anterior cerebral artery on the left and the right, the anterior communicating artery, the internal carotid artery on the left and the right, the posterior cerebral artery left and right, and the posterior communicating artery left and right. And there is an angiogram, just to show you, this is very real. Sometimes you look at pictures and your diagrams, you think, oh, it just looks so unreal. But that circle of Willis is very real, and it's illustrated quite well here. Now, talking about blood and blood flow, let's think about the pathologies of it. The one obvious pathology is stroke. And a stroke is either as a result of thrombosis, which is blood clot in a vessel, or an embolism, which is a blood clot from larger vessels forced into a smaller one. So it's loosened from another artery somewhere and it flows up until it gets stuck into a smaller one. You might have a reduction in blood flow leading to cerebral arteriosclerosis, and here's a good picture of it, where you have, for example, cholesterol packed on the inside of an artery, and then that artery becomes very, very small and can even block, causing a stroke. And then also a type of stroke is a transient ischemia, where you have a little blockage, it gets stuck. For a moment, the person can't speak or they can't walk, but it loosens itself and travels along. And when the blood flow is going and no damage has been done to the cells around, because the blood flow came back quickly enough, the person is fine again. Cerebral hemorrhage is bleeding inside of the brain. As I mentioned before, blood and brain cells do not mix. Blood is really quite toxic to brain cells. So even though the brain needs blood, that blood needs to remain inside of its little veins and arteries. It mustn't bleed into the brain. Angioma is a congenital collection of abnormal vessels that divert normal blood flow, and some people can have this their whole lives and never even know it and not have any symptoms from it. And then an aneurysm is a vascular dilation from localized defects in the elasticity of the vessels. You probably know what an aneurysm is. You have your little artery, and there's a soft area, and with the pressure of the blood, it balloons out, makes like a little balloon. Now that in itself is not a problem, but if it bursts, it's a problem. So I'm going to come back to that in a moment. If through a brain scan, if the doctors notice there's an aneurysm, they're going to want to try and clip it and try and prevent it from ever bleeding, because it causes a stroke, but it can cause death as well. A stroke, as you know, is a blockage of an artery, and the sudden appearance of neurological symptoms such as a result of severe interruption of blood flow. So the person will suddenly become paralyzed on the one side, or the facial muscles will become slack on the one side. And of course it is on the one side, because you know that the left hemisphere controls the right side of your body and the right hemisphere the left. And so that little clot is going to sit in either the left hemisphere or the right hemisphere, depending on which one, that side of the person's body will be affected. And of course, if it's in the left, near Broca's area, they're going to struggle to speak. Here's just a picture of different forms of aneurysms. And this is a picture of an angiography, where a person drinks a certain substance that goes into the blood, and then it's easy to pick up on this type of X-ray thing, and they can see if the blood is flowing as it should through the system. This is an angiogram showing an aneurysm. So the radiologists are very careful to look out for something like this. And as I said, if they see an aneurysm, they try and sort it out immediately. Unfortunately, many people have aneurysms and they never know it until it's burst. And the other aspect of pathology, and this is the last topic of today, I know we've covered quite a lot already, is headaches. Headaches, I think as neuropsychologists, we very seldom see people because they have headaches. However, a lot of our patients do have headaches, and we need to understand where these headaches come from. Now, headaches, it's pain caused by pressure, displacement, or inflammation inside of the head. And the pain-sensitive structures are the dura mater, the large arteries of the brain, and branches of some of the cranial nerves. A lot of the brain, like the brain's tissue itself, it doesn't have any pain sensors. And that is why people can open up your brain and they can prod around in your brain and you don't feel it. But your dura is pain sensitive, and some of the large arteries of the brain and certain cranial nerves. We will be going through all of the cranial nerves, they're important too. And then, of course, you get many people who suffer from migraine, which is a neurological disorder. And they often have an aura, which is as a result of the constriction of one or more cerebral arteries, which produces ischemia of the occipital cortex. But the actual headache begins as a vasoconstriction versus and vasodilation takes place. So you've got vasoconstriction, your little arteries, they go all tight, and they have vasodilation, and that's actually where the headaches happen. Okay. Now, so I just want to go back to this aura. It's because the occipital cortex is involved, and you know the occipital cortex has to do with vision and sight and so on. It's because the occipital cortex is involved that people get visual hallucinations, flashing lights, visual problems. Now you get different types of migraine. Classic, common, you get a cluster headache, you get a hemiplegic migraine, which involves loss of movement of limbs on the one side, and ophthalmologic migraine, which is where people can't move their eyes. Okay. Now that is what we're covering for today. What I want you to go home and read and study before next time is chapter 1 of Cole. I'll send this to you as well. I'll send it with the slides, but I'll also send you a separate email with a reading list on. But sometimes it's difficult to read it from the slide itself. Chapter 2 as well, which is the origins of human brain and behavior. That's just a background information that's important. Chapter 3, which is the organization of the nervous system. Chapter 10, which is, as I said, now you can see I'm sort of jumping ahead, but that chapter 10 has to do with the principles of neocortical functioning. It's really important that you understand that right from the start. And then some other smaller references about cellular organization of the cortex, the structure of the cortex. Chapter 4, which is the structure and electrical activity of neurons. Chapter 5 is the communication between neurons. And then various other smaller references that you need to look up. And the reason I do that, I will each time give you a number of chapters that you need to go through, but I'll also give you smaller references because they're little references in the rest of the book that have to do with what you're dealing with at that time. And it helps to look at it then because your mind is on that topic. And sometimes you look at it again later on when it's included in another chapter. So often you'll say, I'll see you review this, review that. But do try and read it together because I believe it will help you to remember the work and integrate it to help you to study all of this. Is that okay? How are you feeling? Now, I know there are a lot of chapters to get through. Do really try very hard to get through all of that before the next tutorial, because with the next tutorial you get a whole lot more. There's one tutorial, and I'm not going to tell you which one, where there isn't that much reading to do afterwards. I'm not going to tell you which one so you don't expect it. There'll be a little bit of time to catch up then. But I really think if you're determined to write the second exam, don't fall behind in your reading. The moment you fall behind, it's almost impossible to catch up. So if you're feeling you're not getting to this before the next tutorial, then you know you need to make more time. Take a couple of days of work, go sit in a log cabin in a forest somewhere and cut yourself off from people and study the exam. What I can tell you, it's a multiple choice. It's all multiple choice questions. It used to be a 5-hour exam, but they shortened it. So now it's a 3.25-hour exam. It's not. It's a pen and paper test. To know the references and dates and things like that, you just need to look at the information as if I needed to understand a patient, what I need to know about this patient. So you don't need to know who did the research on what and so on. Okay, so on that note, thank you very much. I am going to also linger with tea and coffee, so please feel free to ask me, let me know if you have any questions. Okay. We meet here again next time. Something else I just want to say, I would have loved for there to always be at least 4 weeks between each tutorial. It doesn't quite work out that way. There are times where there are fewer weeks, and maybe one time where it's a bit longer. And there's a tutorial 3. I have to change the date of that because I've got to be in East London the previous day and Durban the following day. So, but I'll send you an email about that today as well, so that you just know already that I'm changing that date. Okay. Thank you so much.